over to Valerie, our lead index developer, to talk through some of our findings with a specific focus on racial inequity and structural racism. And then Pulkit, who leads Sergo's portfolio of US-based projects, including maternal health, will wrap it up with our ideas for how the tool can be used. And then, of course, we will have some time for questions. So we're all from Sergo Ventures, which is a nonprofit that's dedicated to bringing precision to solutions that save and improve lives. And we do that through data science, behavioral science, and artificial intelligence. And our overall goal is to empower decision makers with data and insights. So the Maternal Vulnerability Index, as you'll see, falls pretty squarely into that goal. So I'll start us off by talking through the first couple points of the agenda, what the Maternal Vulnerability Index is, why we built it, and how we built it, along with a live demo of the tool and some of our really high-level findings. So to start, why are we building this tool? As I'm sure you all know, the US has one of the highest rates of maternal mortality amongst high-income countries, and those rates are not decreasing. But in the US, we have a very scattered network of providers and a lack of dedicated surveillance systems for maternal health, which makes it really hard to identify patterns and drivers of poor maternal health at a national level with a high level of precision in order to inform interventions and distribution of services. So maternal health, of course, is incredibly complex, and the drivers of mortality and other poor outcomes often lie outside the traditional maternal and reproductive health sector. So for that reason, a holistic view of environmental and structural risk factors is really necessary. So that's what the Maternal Vulnerability Index does. It gives a holistic view that will allow policymakers and stakeholders to efficiently direct resources towards improving maternal health in this country. So I won't spend too much time here, but before we dive into the MVI, I want to give some brief context on the state of maternal health data in the US. So this might be pretty familiar to a lot of people here, but I think it's really important context for the MVI, especially to highlight two major issues with maternal health data. So the first is that there's no dedicated national surveillance system that includes all the contextual factors that influence maternal health. The closest are the reviews conducted by state-level maternal mortality review committees, who really are best placed to investigate each death in its unique context and to focus on preventability and to focus on those contextual, structural, and environmental factors that influence maternal health. But those data are not available to researchers. And in addition, comparisons across states can be really challenging. In some states, there aren't enough maternal deaths to allow for the release of data on an annual or even 5-year basis. So that really limits our ability to have an up-to-date understanding of maternal mortality. And then none of the data sets highlighted here actually focus on maternal morbidity at all, which is obviously an extremely important component of maternal health generally. Then the second issue I want to highlight is a relative lack of standardization for methodologies in maternal health surveillance. So there are different methodologies used to both identify and define cases of maternal morbidity and mortality used by different systems and stakeholders, and that can make it really difficult to compare across geographies and to understand true trends. So the chart here shows one example of this. The measured maternal mortality ratio is in blue, and then the pregnancy-related maternal mortality ratio is in yellow. So the context in which we created the MVI is this context of relatively low availability of high quality data, especially for researchers. So essentially the MVI is a county and state level index that ranks each county in the US on 43 structural, contextual, and environmental drivers of maternal health outcomes. So it helps us identify not only where, but why mothers are vulnerable to poor outcomes. So I also won't go into too much detail here, but just want to give you a flavor of how we created the MVI. It was a very iterative process. We recognize that vulnerability, much like maternal mortality, is super complex and includes both individual and structural factors. So we're happy to answer any questions about how we constructed the index at the end, but in brief, we had a lot of help from subject matter experts who helped us think through theoretical frameworks to organize our indicators into cohesive modular themes, which you can see here in the middle box. So they range from reproductive health to socioeconomic determinants to physical environment. And those modular themes allow for an easy understanding of the drivers of vulnerability and for targeting interventions to maximize impact. So once we constructed the index, we then validated it using both openly available and individual level restricted data from CDC's National Vital Statistics System. So to give you an idea of what the index looks like before we dive into our findings, we'll do just a really short demo of our website. It's not yet public, but we are launching our tool in September, so this will be publicly available in the next few weeks. And so I'm going to switch over to the website. I'll ask you to just bear with me for a moment while I stop screen sharing. and then go back to it. So just 1 second here. Okay, everyone can see this, right? Awesome. So this is our tool. And the first section here, and apologies, I'm going to be, the tool's over here on my monitor. You guys are over here. So I'm going to be talking slightly at the monitor. Hopefully that's okay with everyone. So the first section here talks about where mothers are vulnerable. So we can see overall vulnerability here with the green map. And then these 6 maps over here are all of our different themes. They're all components of overall vulnerability. So we can look at overall vulnerability, or we can look at this by theme, and we can see how either states or counties compare related to overall vulnerability or any one of these themes. So I want to highlight just a couple counties. If you roll over any of the counties on the map, you'll get a pop-up box that will allow you to see not only the overall vulnerability score, but also all of the theme scores, as well as where available, the state level MMR, maternal mortality rate, and the US MMR. So you can compare, the state level maternal mortality rate to the US maternal mortality rate, and you can also see all the dimensions of vulnerability. So for example, here in North Dakota, we can see that overall vulnerability is pretty low, ranging from 21, 16, 15, but we can also see that some themes score very highly. So reproductive healthcare, for example, scores very high in Foster, North Dakota, which means that this county is highly vulnerable due to reproductive healthcare, even if overall vulnerability is very low. Then if we go down here, we can look, for example, at Alabama, which is much more vulnerable overall than South Dakota or North Dakota. And we can also see that even within a highly vulnerable county or state, there's a lot of variation in terms of how vulnerability shakes out across the themes. So reproductive healthcare here, for example, in Alabama is much better. It's much lower, down at 44. And I should also mention here, the MVI is on a scale of 0 to 100, and 100 is the most vulnerable, 0 is the least vulnerable. So there are also a few links here to explore the indicators that comprise each theme, to explore detailed methods, and then also to download the raw data. If you come down to the second section here, you can look at a specific county or state. You can search for whatever county or state you want in here. I have highlighted this county in Georgia. And when you scroll down here, you can see how mothers in a specific county or state fare due to vulnerability compared to mothers in that state or in the entire country if you're looking at the state level. So here we're looking at the county level. So we're comparing mothers in Chattooga County to mothers throughout Georgia. And this line here is the state average line. So we can see that mothers in Chattooga County overall are more vulnerable than mothers in the state of Georgia. And we can also see that there's some variation in terms of how that shakes out in themes, right? So we can see that mothers in Chattooga County specifically are more vulnerable than mothers in Georgia due to especially reproductive health care, mental health and substance abuse, general health care, and socioeconomic determinants. Whereas due to things like physical environment, they're actually less vulnerable, which means that if we are attempting to intervene on poor maternal health outcomes in Chattooga, we might want to consider interventions that address these themes of vulnerability and maybe less so this theme of vulnerability. So now I'm gonna go back to the slides. Bear with me again, please, for a moment. Okay, so sorry, 1 second. Okay, sorry about that. Can everyone see this? Excellent, okay. So as you could probably see from those maps, geography is really strongly associated with maternal vulnerability. So rural areas, the South and the Midwest, have particularly high concentrations of counties where pregnant women and mothers are exposed to harmful neighborhood conditions across MVI themes. And we can look at vulnerability in a couple different ways. What's shown here in the graph is the average MVI score by region and urbanicity, weighted by the population of women of reproductive age in that area. So looking at it this way, we can see that the average woman of reproductive age lives under higher vulnerability conditions in the South than in any other region. You can see here the score is 60 out of 100. And rural women of reproductive age are particularly at risk. Their average MVI score is 55 compared to only 39 for urban women of reproductive age. So another way we can look at vulnerability is by the percentage of women of reproductive age who are exposed to the very highest levels of vulnerability. So the percentage of women living in areas that score very high on the MVI, which is defined as areas that score over 80 out of 100. So that's not shown in this graph, but looking at it this way, we found that 19% of women live in counties that score very high on the MVI in the South, and in the West and Northeast, that number is less than 1%, and that over a quarter of rural women of reproductive age live in very high vulnerability counties compared to 5% of urban dwellers. And then when we look at outcomes, we see that they follow much the same pattern. So rural residents have a 9% greater probability of severe maternal morbidity and mortality than do urban residents, and the South and Midwest have higher maternal mortality than the Northeast and the West. So now I'm going to turn it over to Valerie to talk us through the next section.
Hi, everyone. Sound check. Does everyone hear me? Yes. Yes, cool. Perfect. So we know that mothers of color are disproportionately exposed to unhealthy environments. And we also know that they are disproportionately affected by adverse maternal health outcomes. The Maternal Vulnerability Index, or NVI, that we have built can help us gain more nuanced insights about these disparities. In this analysis specifically, we're considering the worst possible maternal health outcome, which is death. And pairing the MVI with outcomes data for death, which can be done for severe maternal morbidity or a person of birth with low birth weight, we will answer 3 questions. Is maternal vulnerability associated with mortality? Does differential exposure to vulnerability partly explain the racial maternal mortality gap? And does structural racism further explain the remaining gap? And here, before we move on, we'd like to emphasize that outcomes data, in this case maternal mortality, were not included in the construction of the index at all. To conduct these analyses that I'm going to talk about next, we gathered state-level mortality data from CDC Wonder, but the findings in this section reflect findings from an analysis that we conducted using restricted individual level data. But this analysis we can't share yet publicly. The answer to the first question, is the MVI associated with maternal mortality, is yes. The risk of death does increase with the vulnerability of the mother's state of residence. So when thinking about the racial gap and maternal mortality, one potential explanation behind it is, well, do Black mothers live under worse conditions? But are Black women really more likely to live under these areas on the right, towards the right of this graph, that would have higher vulnerability? And when compared to white women, yes, they are more likely to live in these highly vulnerable counties, specifically about twice as likely than white women. And this can be thought of as a vulnerability gap, right? Or like a differential exposure to these environmental and contextual factors that make them just more prone or more likely to die. The MVI allows us not only to calculate this gap, but further, we can then disaggregate this gap into different themes and understand specifically which conditions are Black and white mothers more or less exposed to when compared to the average woman of reproductive age in the United States. And this next graph is going to show on the left the 6 MVI themes, and each bar shows how much more or less likely a subgroup of women, in this case Black women and white women, are likely to live under very high vulnerability than the average woman in the US. So for example, Black women are about 145% more likely than the average woman to live under high vulnerability for physical health. The physical health theme, it'll be available on the website, all the indicators for each theme, but it includes measures for like STD, hypertension and diabetes prevalence, and just measures of overall physical health. Black women are also more likely to live under high socioeconomic and physical environment constraints, And these patterns reflected here reflect the tendency of Black women to live in urban areas more than other subgroups of women. But this is not to say that the other vulnerabilities should be ignored for Black, for white, or for other groups of women. But this is to highlight the gap in exposures to these different harmful conditions. So Black women are disproportionately exposed to high maternal vulnerability conditions, but where are these disparities more stark geographically? In this next map, we're going to see that in the Northeast in particular, Black women live in counties with much higher MVI scores. For example, in Wisconsin, the average Black woman lives under a vulnerability score of 42, which is moderate, versus 15 for white, which is low. So far, these findings suggest that the differences in the community environment might explain the outcome inequities. So far, we have confirmed that there are more Black women in high vulnerability environments, but beyond that, we'd like to examine if vulnerability could maybe explain part of the mortality gap. So we'll next consider how vulnerability increases with the risk of, how the risk of death increases with vulnerability differently for Black and white mothers. So now we're going to disaggregate this into two lines, one for Black mothers and one for white mothers. In this figure, that's exactly what we see. We have now disaggregated this relationship between MVI and the risk of death by race and ethnicity. And though MMR increases for both groups with the vulnerability of their state of residence, it increases more for Black mothers, which means that Black mothers are a much higher risk under the highest vulnerability conditions. And importantly, the racial MMR gap exists under almost all vulnerability levels. This suggests that interventions that target Black mothers specifically are going to be needed to solve inequities in maternal health outcomes. So now we're gonna visualize the MMR gap and start accounting for these associations between MMR and vulnerability. And first, we want to start with the unadjusted MMR for Black and white mothers. Now we know that A, the risk of death increases with vulnerability. B, Black mothers are more likely to live under high maternal vulnerability conditions. And C, vulnerability impacts Black and white women differently. So once we adjust for these three facts, the MMR reduces from 24 deaths over 100K births to 12 births over 100K births. But as you can see here, vulnerability only explains part of the Black and white MMR gap. So as we were conducting this analysis, we're thinking, what else could we account for to explain part of this racial inequity in health outcomes? And more specifically, we thought about structural racism. Does structural racism explain part of the remaining white-Black maternal mortality gap? There are, of course, limitations when working with structural racism. First, it's very hard to measure. It's very hard to measure in general. It's very hard to measure at a national scale and with precision. Second, existing indicators for structural racism are all very imperfect proxies. The field is still developing. So there's a lot of opportunities to come up with ways of measuring it in robust ways. Third, there's debate over whether proxies used in research are actually measuring structural racism or are measuring the effects of structural racism. And there's also debate over the best unit of analysis for research in structural racism and over the appropriate levels to intervene on health disparities. Sergo, we've brainstormed some proposed solutions, but in the interest of time, we're going to go on to the next slide. So the one measure we'll show in this presentation is called the income rank gap. Essentially, it is a measure of economic mobility, and we calculated it using data from Opportunity Insights. So it is the average income, bear with me, it's complicated. It's the average income percentile for white children who grew up in families in the bottom 25th percentile minus the average income percentile for Black children who grew up in families in the bottom 25th percentile in a given county. So essentially, this measures capture upward and downward intergenerational economic mobility. So once we account for this, this proxy of structural racism, what did we find? We found that the Black and white mortality gap is worst in counties with the greatest economic mobility gap. Now, there are a couple of things that we need to talk about in this indicator. This implicitly captures many aspects of structural racism because economic mobility, even though it's only in the economic domain, is influenced by many structural, institutional, and interpersonal barriers, including those caused by structural racism. But it is based in estimates produced through surveys, and therefore there's a lot of sampling error. And here you can see how the bars and how the uncertainty bars overlap. And there is some error that's not captured in the confidence interval in this slide, because this is only accounting for the modeling errors in the MMR mortality data. So what would happen if, to our previous slide, then we add this, then we account or adjust for this structural racism. Once we do that, the MMR gap reduces substantially. However, there's a lot of uncertainty, like I mentioned before. So in conclusion, state level differences in vulnerability and structural racism explain most of the white-Black mortality gap, but there are, of course, some caveats of working with the data we're working with. What we did was modeling under a low inequity scenario using different proxies for structural racism. We actually only showed one, but we've run this exercise with several ones, and we find similar findings. And our findings in general are that the Black and white MMR gap widens as structural racism increases, and the gap reduces under a low or zero inequity scenario. We've had to adjust what we're modeling for depending on the data that's available. There are, of course, some challenges, like I mentioned, like the lack of availability and other individual level risk factors and measures of provider bias. This specifically applies to our individual level analyses. There aren't that many individual level characteristics between the mortality and the natality data. So that makes it very difficult to control for those things that might make mothers more likely to experience either maternal morbidity or death. Of course, there's also the part of like methods and measurement of structural racism proxies, which we understand it's a very young field. We're excited for the future, and we're always scanning the literature for new developments. And when we try to run this exercise at the individual level, the proxies for structural racism, some are from the same domain, some are from different domains, but they're definitely not additive. So it's not very easy to sort of run this exercise at the individual level, adding one proxy onto the other, because a lot of them are actually highly correlated. So those are things to keep in mind. There are other factors that could be explaining the remaining gaps in racial inequity and maternal mortality in this case, which is the case study we looked at. Some of them are the quality of clinical care, provider bias, other facility level variables, of course, individual behavioral factors, but we all know, I think we're very familiar that these are very difficult to measure at scale and with precision nationally. But the MVI does allow for sort of case studies to be conducted in different, like in a county or within a state. So we hope that you find the MVI useful, and then I'm going to pass along to my colleague, Pulkit.
Great. Thanks so much, Valerie. So the last section that we wanted to cover is just on sort of, usage and what does all this actually mean? So the MVI can be used to target high impact interventions and to understand racial inequity in maternal health. Broadly, that's what we're saying. But if we go to the next slide, there's really kind of, if we disaggregate this, we think that there are four, as of what we've tried to define so far, four major potential uses for this MPI, right? Because again, like while this is certainly, we believe, really important and interesting insights, at the end of the day, we want this to be policy relevant. We want this to be a tool that can actually help to ameliorate some of the the challenges that we see in maternal health in the US and the rising rates, and especially the racial disparities that we see. So given this, at a kind of very high level, these are four areas that we were thinking about, but we would love to discuss, this is kind of a work in progress, and would love to discuss more, with you all, with various different colleagues about ways in which we might be able to extend this. Right now, we're really at the stage where we're coming up on launching this, and we're really excited about that. But in terms of thinking about how do we bring this forward in the most effective way, that is very much a live discussion for us, and would love to partner with others as well. But for what it's worth, there are 4 major areas that we're thinking about right now. The first is in terms of it provides the data needed by advocates and others to take targeted action, right? So this is the whole thing that we've been talking about throughout, that we know that there is a lot of heterogeneity across the country in terms of the specific barriers and the specific underlying reasons for why birthing people are vulnerable to, why they are vulnerable to maternal health poor outcomes. And so what this tool can enable us to do, as Jordan showed, is to really see county by county, what are the specific drivers of that vulnerability, and be specific and precise in targeting those drivers to the communities, to very specific communities, right? And kind of, I might jump down to the third thing here in terms of another way that this targeting works is it's a powerful tool for addressing racial health disparities, right? So again, going to that question of targeting, we know that it's so critical to target this specific question of racial health disparities, and we also know from the work that Valerie was showcasing that the places where Black women and other women of color live are disproportionately higher levels of vulnerability. So we can really find and target those particular communities and find the underlying drivers of vulnerability for those communities, and then have that as one potential option for helping to reduce racial health disparities. Of course, there are other factors around structural racism and within county levels of health disparities that would require a further level of analysis and insight, but at least understanding where some of these most vulnerable communities of color live, and then targeting those health disparities that can get us part of the way there. The other 2 things, one is it provides more complete US data than we've ever had. As Jordan was mentioning at the start, there's a number of different disparate data sets. And so this kind of brings a lot of that information together. But in particular, when we think about this question of vulnerability, there hasn't been this kind of holistic set of indicators that brings together the contextual factors, the structural factors, and the individual level factors to really, get to the point where we can score and think about vulnerability in a really quantitative way, and also holistically and across the entire country. There are places where there might be specific such data sets for individual communities, but the fact that we have this across the US, I think is somewhat unique. And lastly, it can help us inform new legislation at various different levels. There's a number of different legislations, as likely we all know, passing through Congress regularly, that tries to invest in different communities. And this goes back to the point of targeting. We need to understand what are the specific barriers for specific communities so that the interventions can be targeted appropriately. And what works in the South might not be necessarily right for the Northeast. And of course, if we double click on that even further, there's various different levels of heterogeneity in terms of barriers. So that kind of understanding of barriers at various different levels can help to shape and inform legislation at all these different levels as well. So that was some of our early thinking around how this might be useful. And finally, on the last slide, just wanted to say thank you to all of you for listening in. I know we've got a number of different questions coming in as well. We're looking forward to talking through all of those with you. But in particular, if you are a researcher or an advocacy organization, a policymaker, or some other maternal health stakeholder, and you're interested in the work that we're doing in any way, please do reach out to Jordan Her contact information is listed there. We would love to figure out ways to partner. And similarly, if you're a journalist or someone in media and would like to learn more, please reach out to our Director of Communications, Bethany, and her contact information is listed there as well. And on the left-hand side, you can scan that QR code if you want to just stay abreast on the various different sort of updates as we have them coming out for the MVI. We're about to launch our MVI website in the upcoming weeks, and we can provide you updates with when that's happening and other updates as we move along our sort of journey of providing more and more insights and tools for the maternal health portfolio. So absolutely, please sign up there. Our website is listed there. Our Medium link is there as well, along with our Twitter. So I think that's everything for the moment. Yeah, I think I'll pause there and just open it back up for questions and comments. But thank you all for listening in and for all the great questions, and looking forward to diving into some of those now.
Awesome, thanks, Pulkit. So there are lots of questions coming through. Thank you, everybody. So maybe I'll address first, for those of you asking about hospital level data and talking about working with MMRCs, those are absolutely two of the top uses we envision for this tool. We would love to hear from you. We would love to work with people who especially have access to hospital level data. And obviously maternal mortality review committees, we feel like this could be a really good application for the data that we have. So yeah, please definitely get in touch with us. And obviously outside of those two uses, we're also interested in hearing from you if you'd like to work with the tool. So yeah, my email is there, as Pulkit said, please reach out. And then maybe I'll just start at the top of these questions. We can also, if you'd like to come off mute at any time and ask a question live, that works too. And sorry if I butcher anyone's name here, I'm going to do my best. Asta asked if we're looking at pregnancy-related mortality or pregnancy-associated mortality. Right now, the data, Valerie can provide more information, but we're using data from CDC's National Vital Statistics System, which primarily gives us information on the maternal mortality ratio, which means only up to 42 days postpartum. So we recognize that's definitely not optimal, and that pregnancy-related mortality would be ideal, but it's difficult to get access to those data at the national level, for national scale at the county level for researchers. Valerie, you want to add anything there?
Yeah, I just wanted to add there that part of the reason, and I mean, a lot of you here be a lot more familiar with these data. Part of the reason we're using maternal mortality rate is that we see an inflation in the ratio, in the rates when we use pregnancy related. So we're following CDC recommendations of like filtering out late maternal deaths, and also not, official guidance from the CDC in terms of like age and ICD codes to use, but also in terms of filtering out those late deaths, because they do seem to add quite a lot to the ones that occur within 42 days. If you wanted to look at pregnancy-related mortality or pregnancy-associated mortality asset, we're more than open to do that. I think our idea is that this can be repeated with sort of any maternal health outcome. So we're more than happy to continue this conversation offline.
Hi, Valerie, sorry, just one follow-up question. When you say you're looking at deaths up to 42 days, are you looking at sort of any kind of death? Like it could be a drug overdose, it could be anything, or are you looking at specific pregnancy related, sort of like a cardiomyopathy or a hemorrhage or something like that? That was, I think, like
we're not looking
the flavor of my question.
Sorry, I wrote it down because I figured this question would. So we're going with death of a woman while pregnant or within 42 days of termination of pregnancy from any cause related or aggravated by pregnancy, but not from accidental or incidental causes.
I guess my question is, how do you know that.
We filter out, we're filtering out by ICD codes on CDC Wonder. So whatever is on CDC Wonder is what we're going with, because we don't have access to like more detail on those.
And
deaths.
CDC Wonder is information from death certificates only. So it's not an optimal data source in any way, because there's a lot of ambiguity about, like it's mainly based on the pregnancy checkbox, which there are a lot of issues with.
Right. And like, I'm just thinking like diagnosis codes, while some of them could be, certainly there's like slam dunks, like hemorrhages that are absolutely related to a pregnancy, but those sort of like gray areas around like suicide or, a drug overdose that potentially could be related to the pregnancy, but we don't have like a standard way of defining like how to, so we're kind of missing like this whole group of deaths that would actually, I think even benefit more from a vulnerability index and like thinking about these social determinants, outside of sort of these like just brute medical causes. And that was what, why I asked.
Absolutely.
We completely agree with you. And I think that's why we wanted to present this. And I think there's an opportunity. I know that some maternal mortality review committees are already integrating geospatial determinants of health, but we're more than happy, like if there are states that are interested, because we know that states have access to sort of a more nuanced data on like what caused the death and like, was it preventable, was it not preventable? We're more than happy to partner up with states or counties to look at these data together, because we agree with you. There's a lot of gray area there that we as research, external researchers, we really don't have access to and won't, from what I understand.
Yeah,
I'm sorry, this is Becky Moore Patterson. I just wanted to jump in for a minute. I'm the project director for the North Carolina Maternal Mortality Review Program. And I can tell you that the CDC is actually looking a lot more at social determinants of health and behavioral health, and have been for a while. There was the ARMOR grant, which reviewed substance overdose deaths to a certain number of states, and they should have that data out. But then lots of states, as you said, have been doing social determinants of health. In North Carolina, we've been doing it for about 3 years, where we pulled in our behavior health, substance use, and then the social determinants of health as well. So those hopefully are going to get better incorporated into both the narratives and the data.
Awesome. Thank you so much, Vicki. Yeah, we know that some states are doing it. And we know, we've read the materials coming from CDC and Erase MM and all those things. So.
And I think, one thing to highlight about the tool itself is that while we did validate it using mortality data, there's no mortality data contained in the index itself. So it really is more of a, it's not a predictive tool. It's more a measure of how good maternal health is likely to be in a given area, which I think, in the absence of a really robust surveillance system that does include those deaths, like overdose deaths and things like that, I think it can be helpful in figuring out where a mother is likely to be more vulnerable to poor outcomes versus good outcomes. And yes, to these last couple of questions, we have not yet really looked at SMM, as I'm sure severe maternal mortality, as I'm sure most people here are aware. It's a pretty complicated indicator, and we struggled with a few things, including like hospital level case mix, and how to sort of account for the fact that hospitals that tend to get a lot of very complicated maternal mortality, very complicated maternal morbidity cases also tend to be hospitals that can handle those cases. And then at the same time, there are several interventions that are life-saving for severe maternal morbidity, but that are also used to measure severe maternal morbidity. So it's been a little bit challenging to look at SMM, but that is definitely something that we're thinking about for the future. And then to Vera, yes, we have contacted the Maria team at CDC. We've been talking to Dave Goodman, and he's been absolutely wonderful. And we're very, very much interested in taking this work forward, both at the national level with Maria and then also at the state level with individual MMRCs. Anyone, did I miss anyone? Sorry if I missed you. I'm scrolling
I
up.
think
through these.
there was a question about how often will the MVI be updated?
Yes.
So we actually, this is an ongoing internal discussion that Pulkit has brought up a couple of times. So a lot of the data sources we use are not updated, say, like a monthly or quarterly basis, or more updated on like a yearly basis. We use a lot of indicators from the American Community Survey and some other organizations. So we're considering updating it on a yearly basis, but it's solely because of the how often the data are going to be updated. We think that anything more frequently than that is probably not going to add much value. And there was a question, Jordan, about have you explored how to partner with hospitals? There were two questions about hospitals. So the first one was, well, these data will be correlated to hospitals in the area so we can connect hospital-based SMM to more community-based structural process of SMM. So at Circle, we right now don't have any access to hospital level data, but we would be more than happy to assist you with this connection between hospital and SMM data. And there's a potential to, if you have very detailed data about the hospitals, there is potential for some of these indicators to get like census tract level, like from American Community Survey, census tract level data, for example. So we're very interested in carrying this conversation forward. Tisha, thank you so much for your question. And then Jordan, can you take have you explored how to partner with hospitals? I'm based in CA with recently passed legislation to address implicit bias at the hospital level with clinical care teams.
Yeah, just generally very, very interested in taking forward any analysis that combines the MVI and hospital level data. We'd love to talk further. Yeah, Pulkit, anything to add?
No, just that especially like we're very open to like any ways in which we haven't had access to that data as we've mentioned, and so that's been part of the challenge. But I think if there are people who have access to that, it might also open up, it would be interesting to have a conversation to see ways in which we might be able to create synergies or create more sort of sophisticated insights that might be helpful for hospital administrators or for other stakeholders that in the absence of having that detailed data, we're not able to quite fully see. So yeah, just underscoring the point that if Keisha or others have any access to that data or would like to brainstorm about ways in which there's a possibility to link any of this, we would love to have that conversation. And the other thing I might mention is just, I think, was it, I might be missing this, but was it Becky or maybe someone else from an MMRC that is on this call? If so, would just definitely, I think, from our standpoint, that is a key place that we might see a potential option for collaboration, or seeing if it's definitely true that there are other sort of avenues and organizations that are supporting social determinants work as well. So it's but just would love to just see if there's some route there for collaboration, because definitely the state level and being able to see the sort of heterogeneity across individual states when it comes to contextual and individual factors seems like a key place, at least as per our understanding and an opinion of where this might be helpful.
Yeah, and we're, as I said, we're making it available on the website, but at the same time, we think that probably one of the best applications of the tool would be to, tweak it in response to whatever specific localities need. So we're fully open to conversations about adding specific indicators or, connecting it with other data sets, depending on, your locality and what specifically you might need for your application of it.
Thank you. That sounds great. Thanks for reaching out. That'll be great.
Susanna, do you mean the CDC Social Vulnerability Index? Yeah, okay. Yeah, definitely. We're using a lot of similar measures from the CDC's Social Vulnerability Index, but we've added a few, more than a few measures that are highly specific to maternal health. And we did do a little bit of analysis related to, how the Maternal Vulnerability Index and the Social Vulnerability Index overlap or correlate, and we found pretty high correlation between the two. But we think it's useful to have the additional indicators and themes related specifically to maternal health, because a few things are not included in the Social Vulnerability Index that we might want to think about, maternal health outcomes specifically. Anyone else? Anyone want to come off mute?
Yeah, we'd love to just talk live if anyone has any other thoughts.
So those of you who have reached out, thank you first, and second, we will obviously continue the conversation very, very soon. Thank you so much.
We actually went faster than anticipated.
Yeah.
We'll hang around in case anybody has any more questions. When will the index be available? Sometime in September. Our launch date is a bit up in the air right now, but definitely by the end of September. And if you sign up for the mailing list, you'll get an update when it launches.
Thanks. We're also looking forward to talking more, to more person.
And how do you envision working with states? Because it's a national level tool, so the state would bring the data, the state level data or nuanced data, and you'll be able to reflect it in the dashboard. This is Vera, I'm from Florida.
Hey, Vera. Sorry, and you're referring to like the Florida Review Committee, right?
Yes, so yes, I work for the Florida Department of Health. I am an analyst, so I know the process, I know the data. So I think the tool is amazing. I know CDC is working on a similar tool. I would like to see how they compare to be integrated with Maria, but yours is open source, which is awesome. So thank you for all your hard work. So I was wondering, when you kept mentioning that you're interested in collaborating with states, so how do you envision that collaboration?
Yeah, so we from what we understand, and rightly so, the MMRC data is not available to external researchers. So I think that we could find ways to technically assist you in bringing our data into whatever system you're using, if that's of interest. But I think depending on the need, obviously, we can continue discussing this offline, Vera, but we're more than happy to assist you in pairing up the data. But that's my understanding that those data are not going to be available to external researchers, right, Jordan?
Yeah, I think, I would just add to that and say, whatever would be helpful for you. To be honest, this is kind of our first foray into US-based maternal health, and we know that there's a lot of national guidelines for MMRCs especially, and that MMRCs receive technical assistance from the CDC, but we also know that each MMRC does, kind of do its own thing sometimes, depending on, the local context and what that state needs. So we're happy to kind of customize to whatever you might need at the state level. And we'd love to hear from you what would be useful to you, because we we can take this forward in a lot of different ways. And I think, we'd love to hear from people who will actually be using it, what additional functionality would be helpful, or what other changes might be needed.
Okay, so I need to be thinking about it more like as a way to integrate it with the current, whatever data we have, whatever systems we're using, to somehow integrate that. So we should be able to look and get the answers that we're looking for.
If you'd like, yeah.
Okay.
We have data. Sorry, we have currently our data are available at the FIPS code level, at the county level, and then we can also do state level. So if you have data at that FIPS code level, we can really easily join it. And if you have data at the zip code level, we can also do a crosswalk there. But it can also be used on its own. If you really just want to look at which counties in your state are vulnerable due to specific things or more vulnerable overall, it can be used in that way as well without linking it to any other data sets.
Thank you. Thank you very much.
Thank you.
Maybe
Pulkit, you want to?
Oh no, I think that all of that is spot on. I guess maybe just because we have you here, Fira, just curious if you had thoughts about, like, it sounds like that integration with our vulnerability index integrated with some of your data sets might be helpful, and happy to discuss ways in which that's possible. But I was curious if you had any initial thoughts about just the extent to which, as Jordan's saying, this is our kind of first foray in. Vera, or honestly others on this group, you have thoughts on some of our theories of the case here in terms of use cases of bringing together all these different contextual factors to be able to really think about, okay, if there's such a range of different interventions that are possible to ameliorate maternal health challenges, then this tool might be able to help to pinpoint which are the right sort of barriers to target in different communities. And curious if you feel like that in and of itself has some level of benefit, and how it might fit with some of the work that you're currently doing.
Thank you for your question. I think that there is a huge need for contextualizing and identifying social kind of context, socioeconomic context. And I think, and I can speak only for Florida, but I feel like that context is missing, or we're not getting. Sometimes we really would like to know kind of the environment that a woman lived in or experienced from the standpoint of, I would say, socioeconomic inequality and barriers and all the other issues, because they're not really, not always reflected in the cases. Right. And I feel like, and I may be biased because, again, I'm a sociologist and political scientist by training. So I would like to see more of that. And again, we should be continuing the conversation offline, but I would talk to my team too. And I'm excited, to see the tool. I know it will integrate well, especially if we can merge by zip code. But again, I don't think we work with restricted data, as you said. So, and I don't know even like how, and again, it's a conversation for us. How to forge a collaboration if possible, but that there is a huge need for that. And I think the themes that you're identifying, and they're informed by the literature in terms of interventions, I didn't know. So the interventions, it's usually committee recommendations, right? That is the outcome of the review of maternal death. And they're very, again, I feel we're missing because, again, mostly it's committee members making recommendations, right? Say you won't see policy level recommendations. So again, extending Medicaid, for instance, to cover pregnant women, say 1 year postpartum, it's kind of a policy level recommendation, or providing health insurance. But if there are other underlying factors that your dashboard kind of shows and hints at, there are more than that. It's like what we call the life course perspective, right? And the importance of interconception health, preconception health. We can look at more interventions then. And I don't know if you're thinking of integrating, that's an idea, review the systematic reviews the literature reviews and see if there are interventions beyond medical interventions, right, to go hand in hand with your tool and maybe put references or even like assess the evidence, the strength of evidence behind those interventions. Yeah.
Yeah,
Again, I'm personally very much interested in this particular kind of aspect of bringing the context to maternal death, because I feel like if we don't address the structural issues, we might not get far.
yeah.
Racial disparities too. So, yeah, thank you.
Yeah, just thank you for that insight, Vera. That's really helpful to understand. Especially where you're coming from in terms of what might be helpful for you, and definitely happy to would love to take forward that conversation with yourself about maybe ways that we can integrate or think about specifically where there might be points of collaboration, and would open that up to others as well. Please do reach out to us if you see any potential there. And just on that specific comment, I think on intervention, sort of the strength of different interventions and going beyond sort of maternal health to a sort of broader set of interventions. I think that's very much in the spirit of what we're trying to do here with the MVI, thinking about, where does food insecurity or cash disbursements that have to do with poverty or housing vouchers or what have you, what is the sort of broader social determinants of health that, and specifically maternal health, that exist, and what are the broader suite of interventions that are possible to attack these? Because sometimes it really is some of those, if we see that the driver is predominantly having to do with housing insecurity, and that is the primary sort of like case for vulnerability, that points to a different set of interventions than if it was the driver was primarily focused on reproductive health or something like that. So I do think that that's the kind of idea behind what we're trying to do here. And in terms of developing scorecards or some sort of analysis of the strength of different interventions, I think it's a live possibility. I think it's something that we've talked about. The trickiness is, of course, as you I'm sure are more versed in than we are. There is just such a range of contextual factors that come in when you have to think about the effectiveness of different interventions. And so I think the way we were thinking about this is maybe there's there's a way to integrate a breadth of interventions or something to be considered, with the philosophy being that we're trying to provide some data and evidence towards the right path, but knowing that this is not a predictive tool. We don't want to say that this is the end-all be-all specific intervention that should be targeted in a sort of prescriptive manner, but rather thinking about a suite of different possibilities as maybe certain suite of possibilities maybe being more important than another suite, just based on what we see in the data. But then eventually the choices of what should be done at the end still lay with the specific context and decision makers. But again, that's a philosophy that we have right now, and would love to just discuss more about different ways to think about this and how to sharpen the tool so that it's actually useful.
We only have a few minutes left, so I wanted to say, we thought long and hard about how to weigh the different themes, and I'm not sure actually this is what you're referring to. We thought a lot about it. We just didn't have enough outcomes data to sort of validate and provide weights to each indicator and or theme. So we're more than happy to continue this conversation offline. I think we have less than a minute now, so any last.
Oh, we're 45 after? I thought we had the hour.
Oh, I thought it was until 45.
I think it's 45.
Oh, okay. Anything else? Any last one?
When you're looking at causal modeling, are you using path models? That's what you have in mind?
Valerie,
That's exciting if you do.
Sorry, so can you elaborate a little bit? What do you refer to as? And I'm sorry, I'm a totally technical person, so we might be talking about the same thing just in different words. So what do you mean about path?
There is the structural equation models.
Oh yeah, so it's not exactly structural equation models, but it's related to it, yes. So it's like there's a directed acyclic graph, and so it's I think we should carry this conversation offline and have Vincent actually join us. He's the expert in causal modeling. I'm not. I'm doing a very poor job here. But you can look at some of our applications in our website about causal modeling, and perhaps if that's what you're referring to, I think it's better to look at what we've done in the past and what we can do.
Yeah, the analysis is very much in its infancy, but the point is we would love to be able to tease out which factors are most important. And I think in terms of, especially with hospital, if we could link with hospital level data and then do some causal analysis, including the themes or the indicators in the vulnerability index, I think that would be really interesting. So yeah, it's something we're exploring. And if folks are interested in talking more, we'd love to connect.
Yeah,
okay.
and our AI director, Vincent, can provide a lot more information about this. Sorry, Vera, I'm not too familiar in this subject.
It's just super exciting that somebody's thinking about that there's a way to model it beyond, just simple regression models. Yeah. Thank you.
We're excited too.
Yeah.
Thank you. Awesome. We're a minute over, so.
Cool. Thank you so much, everyone, for joining. And thank you for all of your questions and all of your feedback. And we're looking forward to talking more in the future. So
Please do reach out. Looking forward to connecting offline as well.
Yeah, for sure.
Thanks, everyone.
Thank you.
Have a good day.